Hello, I'm Dr. Nicole Kim from the University of Washington. In this Hepatitis C online mini lecture, I will be reviewing the risk of hepatocellular carcinoma, or HCC, before and after hepatitis C cure, and when to perform HCC surveillance. This is my disclosure. In this mini lecture, I'll first review the natural history of untreated hepatitis C infection. I will then review the risk of HCC before and after hepatitis C cure. Finally, I'll review the evidence to support HCC surveillance after hepatitis C cure, including who to screen and for how long to screen. This is the natural history of untreated hepatitis C infection. Approximately 20 to 30% of patients will develop liver cirrhosis, which can result in decompensated liver disease and further increase the risk of hepatocellular carcinoma, or HCC. The risk of HCC is estimated to be 1 to 4% per year, and this risk is significantly higher in hepatitis C than in other etiologies of liver disease. The good news is that treatment of hepatitis C can significantly reduce the risk of future HCC. This decline in risk occurs with both interferon and direct-acting antiviral, or DAA therapies. In this study of over 62,000 patients who initiated hepatitis C treatment, hepatitis C cure was associated with a substantial reduction in HCC risk. After interferon therapy, the risk of HCC declined by 68%. After DAA therapy, the risk of HCC declined by 71%. However, the risk of HCC was not completely zero. It is therefore important to understand how HCC risk changes after treatment. Since 2014, over 12 million people with hepatitis C have received DAA treatment. As more patients achieve hepatitis C cure with the increased availability of DAA therapy, knowing which of these patients remain at high risk for HCC is critical to promoting the early detection of HCC. The main purpose of HCC surveillance is to try to identify early-stage HCC when curative treatment is possible. The American Association for the Study of Liver Diseases, or AASLD, recommends HCC surveillance using an abdominal ultrasound and a serum alpha-fetoprotein, or AFP test, every 6 months. HCC surveillance is recommended for patient populations at highest risk for developing HCC, which includes individuals with cirrhosis of any etiology, including hepatitis C, and select patients with chronic hepatitis B, even without cirrhosis. In general, HCC surveillance is considered cost-effective when the annual HCC risk exceeds 1%. Whether to continue HCC surveillance after hepatitis C cure is therefore also dependent on HCC risk after treatment. So how do we know what the risk of HCC is after hepatitis C cure? Multiple studies have shown that pretreatment liver fibrosis stage is what matters most. In this study, the authors evaluated HCC incidence based on pretreatment cirrhosis status and fibrosis 4 or FIB4 score among more than 29,000 patients who achieved hepatitis C cure with DAA therapy. They found that the risk of HCC was highest in patients who had pretreatment cirrhosis with a high FIB4 score of at least 3.25, followed by those with cirrhosis with a low FIB4 score of less than 3.25, and then those without cirrhosis but a high FIB4 score. In these three groups, the risk of HCC was near or exceeding the cost-effective threshold of 1% per year. In contrast, the risk of HCC was far lower in patients without cirrhosis with a low FIB4 score. In a subsequent systematic review and meta-analysis, we also found that the risk of HCC after hepatitis C cure varied by pretreatment fibrosis stage. Among patients with cirrhosis, the risk was 2.99 per 100 person years, again exceeding the cost-effective threshold. However, it was far lower in patients with F3 or no cirrhosis at 0.47 to 0.63 per 100 person years, which is far below the cost-effective threshold. Finally, using more contemporary data, the study of over 75,000 U.S. veterans who achieved hepatitis C cure found that HCC incidence declines as patients are further out from their date of cure. However, this risk still exceeded the cost-effective threshold for HCC surveillance, even 6 years after achieving cure. These results are also similar to a prior study that showed that the risk of HCC remained high even 10 years after achieving cure. In contrast, those without cirrhosis had a very stably low risk of HCC that remained far below the cost-effective threshold for HCC surveillance. For these reasons, although the risk of HCC significantly declines after hepatitis C cure, the AASLD guidelines recommend indefinite HCC surveillance only in patients who had pre-treatment cirrhosis. In all other patients, there is currently insufficient data to support routine surveillance before or after hepatitis C cure. These recommendations may change over time as we learn more about risk stratification in surveillance and what it means when people have post-treatment improvement in liver fibrosis. In summary, it is important to know that treatment of hepatitis C reduces but does not eliminate the risk of future HCC. The recommendation for HCC surveillance still relies on pretreatment fibrosis stage. In patients with liver cirrhosis before hepatitis C treatment, HCC surveillance should be continued after treatment and indefinitely. In patients without cirrhosis, including F2 or F3 fibrosis before treatment, there is insufficient data to recommend surveillance.
The production of this Hepatitis C online mini-lecture was supported by a cooperative agreement from the Centers for Disease Control and Prevention, CDC, RFA, PS 212105. This project is led by the University of Washington Infectious Diseases Education and Assessment Program.